Thank you very much. Right now, it's my great pleasure to introduce our next speaker, and it's our co-chairman from Cairo University. You know him very well. He's Professor Amr Elmeligi. He will speak about anti-obesity drugs, classes, indications, and efficacy. Professor, the stage is yours.
Assalamu alaikum. I will speak today about anti-obesity drugs. I will first present a case. It's a real case. It's a 37-year-old engineer, single, Layla. Her BMI is 34. She followed different diets and exercise programs under supervision of a dietitian and gym trainer for last year, with only loss of 3 kilograms. She has the following comorbidities. She has prediabetes, hypertension, and chronic backache. She receives metformin, losartan, and citalopram. Citalopram cipralex is commonly used selective serotonin reuptake inhibitors and is associated with weight gain about 7%. She often needs short-term course of oxycodone and acetaminophen for back pain. Oxycodone is a synthetic opiate. Layla came because she feels frustrated. She suffers weight stigma and bias in her work, in the community, in the bus, in the supermarket. She feels frustrated and she's not happy. She came counseling about other methods to lose weight, as she worried also about getting diabetes or heart attack. Current weight loss interventions are diet, increased physical activity, and behavior therapy, and this is a basic component in the management of obesity. Number 2, obesity pharmacotherapy and bariatric surgery. These are the 3 options available at the time being. What would you do next? Do you like to offer more aggressive intensive life therapy intervention? Do you like to prescribe anti-obesity medication or to refer to metabolic surgery? Let us see the current guidelines. Current guidelines recommend that individuals who have attempted lifestyle improvement and behavioral interventions and continue to have BMI 30 or more kilogram per meter square or 27 or more kilogram per meter square with an obesity-related comorbidity are eligible for weight loss medications. So remember, 30 only, or 27 and one obesity-related comorbidity. There are important considerations should be taken into account when you prescribe anti-obesity medications. First, body mass index, but it's not only thing to consider in prescribing or before prescribing anti-obesity medications. You have to search, or you have to screen the patient for obesity-related complications as prediabetes, hypertension, dyslipidemia, cardiovascular disease, NAFLD, osteoarthritis, GERD, PCO, obstructive sleep apnea. All these conditions should be searched for. Also, we have to review the current medications. Why? To avoid interactions. This is one cause, and whenever possible, minimize medications for comorbid conditions with the potential of weight gain. Also, counseling for contraception is important. Women in childbearing period should be counseled for a reliable method for contraception. All anti-obesity drugs are teratogenic and are not recommended in pregnancy and are contraindicated in pregnancy or in women planning for pregnancy at the near future. Also, we have to screen the patient for, or we have to ask the patient and screen for eating abnormalities, eating pattern, physical activity, and sleep quality, also screening for mood disorders. There are some clinical tips. Number 1, the physician and the patient should realize that obesity is a chronic disease. Number 2, anti-obesity drugs or anything for anti-obesity drugs should be given in adjunct with increasing physical activity, diet, and behavioral interventions. Number 3, obesity pharmacotherapy is considered effective if 5% or more weight loss is achieved at 3 months of use, and further weight loss is likely with continued use. Consider discontinuation of the medication and evaluate for alternative medication or other treatment approaches if early response is insufficient. If the patient if the patient lost less than 5% in the last 3 months, during 3 months period of pharmacotherapy. Using anti-obesity drugs, which drug for which patient? There are many drugs approved by FDA. I will speak only on the drugs approved by FDA. There are also some drugs waiting approval. FDA approved anti-obesity medications. One drug is phentermine. For short-term treatment is sympathomimetic. Drugs approved for long treatment, orlistat, which is a lipase inhibitor. Phentermine topiramate is a sympathomimetic. GABAminergic. Topiramate is anticonvulsant and it is used for treating of epilepsy, and they notice that when the patient use topiramate, they lose weight, so it's included as anti-obesity drug. Naltrexone is anti-opiate. Naltrexone, bupropion, this is opioid antagonist, and bupropion is antidepressant. But the same, they notice that patients receiving naltrexone or bupropion lose weight when use these drugs, so these drugs are combined together as anti-obesity drug. Last, glucagon-like peptide 1 receptor agonist, liraglutide, 3 milligram per day subcutaneous, and semaglutide 2.4 milligram subcutaneous once weekly. Other drugs still waiting approval. Oral semaglutide 50 milligram is a GLP-1 receptor agonist, and once weekly tirzepatide, GLP-1 GIP receptor dual agonist. The third drug is rutiritide. This is a triple agonist, GLP-1 GIP glucagon receptor triagonist. It's called triple G and is in phase 3 now. First, lipase inhibitor, orlistat. It inhibits gastric and pancreatic lipase, inhibiting breaking down of dietary triglyceride in the intestine and into non-absorbable fatty acids and monoglycerides. The dose from 60 to 120 milligram per day. It associated with weight loss from baseline at 1 year by 9.6% at high dose 120 milligram 3 times daily. Common side effects are GIT, abdominal pain, flatulence, oily spotting, and fecal urgency. All these symptoms are annoying for many patients. Possible safety concern and considerations. Potential malabsorption of fat-soluble vitamins, also certain medications as cyclosporin, thyroid hormones, and anticonvulsants. Elevated liver enzymes and rarely acute liver failure, nephrolysis and oxalate nephropathy and cholestasis. Regarding the other drugs, phentermine topiramate, and naltrexone, bupropion, all these drugs act on the appetite regulating centers or neurons in the hypothalamus. They decrease appetite and increase satiety. As I have mentioned, phentermine is approved by the FDA for short term only, for no more than 12 weeks, because tolerance occur and weight loss plateaus. Weight loss with phentermine and naltrexone, bupropion is 6 to 5 or 6%. Is small loss. Regarding phentermine topiramate, loss of weight occur by 15% at 1 year at the high dose, at the maximal dose, which is 15/92. Side effects are common with these drugs, including dry mouth, insomnia, irritability, dizziness. Also with phentermine topiramate, mood changes occur, paresthesia, dyschezia, Also, with naltrexone, bupropion, the agitation and mood changes occur. All of these drugs increase blood pressure and cause tachycardia. So there is a concern in cardiac patients and patients with uncontrolled hypertension. Other safety concern for phentermine, contraindicated with MAO inhibitors, active coronary heart disease, and hyperthyroidism. Also, co-treatment with selective serotonin reuptake inhibitor as citalopram increase the side effects of phentermine and can precipitate serotonin syndrome, which is a fatal condition. And the patient should be hospitalized in the ER by these conditions. Rare, but is a life-threatening condition. Phentermine also, phentermine topiramate, also contraindicated with MAO inhibitors, associated with suicide thoughts, can precipitate acute angle glaucoma in patients with glaucoma, metabolic acidosis, renal stones. Also, the same effects occur because the phentermine component, it's not advised to be combined with selective serotonin reuptake inhibitors. Regarding naltrexone bupropion, contraindicated in uncontrolled hypertension or epilepsy because it can precipitate epilepsy, decrease the threshold for the seizures. Hyperthyroidism, so it's associated with suicide thoughts in young age, so it's not allowed below 25 years. The combination of naltrexone with opiate result in one of two. Either naltrexone neutralizes the effect of the opiate, so the patient takes more dose and enters in opiate overdose, or naltrexone antagonizes the effect of the opiate and suffer from opiate withdrawal symptoms. Bupropion with the selective serotonin reuptake inhibitors combination result in increased seizure risk. Regarding GLP-1 receptor agonists, currently liraglutide 3 mg subcutaneous once daily and semaglutide 2.4 mg subcutaneous once weekly are FDA approved for long-term management in adults with conjunction with low-calorie meal plan and increased physical activity. GLP-1 receptor agonists, how do they work? They decrease, they work on the appetite regulating centers, decrease hunger, satiety. Also, they cause delay of gastric emptying and result in stomach fullness. First, the liraglutide 3 mg versus placebo, in addition to lifestyle management, weight reduction, diet and increased physical activity. Liraglutide was compared versus placebo in patients who are obese or overweight with BMI 27 or more with one obesity-related morbidity. Liraglutide was associated with reduction of body weight by 8.6% at 56 weeks versus placebo 2.6% only. Also, the percent of reduction of body weight by 5%, 63% of patients lost 5% or more of body weight versus 27%. Percentage of patients who lost more than 10% of body weight, 33% versus with liraglutide versus placebo. So liraglutide 3 mg resulted in clinically meaningful reduction in body weight in obese or overweight people without type 2 diabetes. This study included patients without 2 diabetes. And improved metabolic profile versus placebo. Improved profile how? They decreased waist circumference, hemoglobin A1C, fasting glucose, also improved cardiometabolic variables as reduction in blood pressure, improvement in lipid profile, decreased high sensitivity CRP, and increased adiponectin. Liraglutide also delayed or decrease the risk of developing diabetes in patients with prediabetes when compared liraglutide versus placebo in obese or overweight patients with prediabetes. Participants diagnosed with type 2 diabetes were 6% in the placebo group versus 2% in the liraglutide group at 160 weeks. Regression to normal glycemia occurred in 66% of patients who received liraglutide versus 36% for patients who received placebo and lifestyle. Change in weight was 7% with liraglutide and 2% with placebo. So liraglutide decreased risk for progression to type 2 diabetes by 80% at 160 week. Time to onset of diabetes with liraglutide is 2.7 times with placebo. Once weekly semaglutide, the same study design, also decreased weight at the end of the study, which was 6 to 8 weeks in patients, in obese patients or overweight patients without diabetes, decreased weight by 15% versus 2.4% with the placebo. 86% of patients lost 5% or more of body weight. One half of patients lost 15% of body weight, and 1/3 of patients lost 20% of body weight. This was also associated with improvement in metabolic parameters as decreased waist to hip ratio, waist circumference, systolic pressure, lowering or improving lipid profile, and reversing type 2 diabetes. Semaglutide effect is sustained. Patients who lost weight in step 1 study, which is a study in patients with obesity or overweight who lost 15% of their body weight, continued to or maintain this loss of weight up to 2 years. However, after discontinuation of the drug, and this occurred not only with semaglutide, with all GLP-1 receptor agonists, weight regain occurred in 2/3 of patients. However, the body weight is 5.6% below the baseline before starting semaglutide. These drugs are mentioned by Professor Tadjana. Oral semaglutide, 50 milligram, is tested and was found to give the same effects as semaglutide, injectable semaglutide once weekly, 15% reduction in weight versus 2.4% with the placebo and diet and exercise. 85% of patients lost 5% or more of body weight. Tirzepatide, which is dual agonist, GLP-1 GIP agonist, was also once weekly, was also associated with reduction in weight in the different doses, 5, 10, and 15 milligram. With 55 milligram was associated with reduction of weight by 15%, where 10 milligram by 20%, where 15 milligram by 21%. About 90% of patients at the different doses lost 5% of their body weight or more, versus placebo, 35% of participants only. As you know, tirzepatide is considered by the ADA in their guidelines, ADA-ACD, as as drug of high efficacy for lowering A1C and for body weight. Very high efficacy drug. The third is the triple agonist retatrutide. This is in phase 2 and showed encouraging results with reduction of weight by 22.8% with 8 milligram and 24% with 12 milligram. Side effects, most side effects with this group of drugs are nausea and mild GIT symptoms. To avoid GIT side effects, escalate the dose gradually to reach the weight management recommended dose. Weight management recommend to avoid GIT side effects, escalate the dose gradually to reach the weight management recommended dose, which is 2.4 milligram once weekly for semaglutide and 3 milligram liraglutide. Otherwise, stop the drug. If you the patient cannot tolerate to take this dose, the drug will not be effective. These are recommendations of AGAs, not my recommendations. Other safety concern, contraindicated in patients with previous pancreatitis, gallstones controversial, also in cell is associated with C-cell thyroid cancer in rodent but not in man. This so not allowed in patients with history or family history of this condition. Weight regain is problem with these drugs, and طبعا the cost is limiting, and being injectable drugs is another factor. To choose for what to do for Miss Layla, she needs psychological counseling. She should be referred to psychiatrist because she receives drug with weight increasing potential. She has depression. She has weight stigma, and she has weight bias, and she should be referred to psychiatrist. As the professor said from a few minutes, multidisciplinary approach is important. All special psychiatrician, dietitian, physician, all are needed for the management of these patients. If we prescribe for her GLP-1 receptor agonist, we start with, we will give her liraglutide, the choice for liraglutide. According to her case, she is hypertensive, she has psychiatric problem, and not nice or not good to give the old drugs. We can give liraglutide 3 milligram per day subcutaneously, or semaglutide 2.4 milligram once weekly are the most appropriate drugs for Ms. Layla. She receives these drugs to reduce her weight and prevent diabetes and improve her cardiometabolic risk factors. We have to start with small dose with gradual escalation in addition to diet, increased physical activity, and behavioral therapy. Thank you.